Well, good afternoon. I want to thank everyone to our first forum from the Center for Strategy and Innovation. Unfortunately, Dr. Coye is not available to be here due to traffic issues, which I think, but we're glad to have her via WebEx. I want to talk a little bit about the Center for Strategy and Innovation and what we're doing. About a little over a year ago, as we actually began what you saw unveiled today with Vision 2020, began the process of how do we develop the strategy that will make Vision 2020 a reality. Buildings are one part of it. What we do in buildings, what we do around buildings, what we do in community is really what makes the difference. And you heard today a lot of the word transformation. And innovation is one of the processes in which we make transformation happen. And so the Center for Strategy and Innovation formed, one, to develop the strategies and actions to make Vision 2020 a reality, and to help lead the organization through that process, and also to develop a competency throughout our organization in innovation, and to be able to facilitate innovative programs across the organization. And so we are in the early stages of development there, and one of the things we wanted to do is to start doing regular forums, bringing in world-class speakers like Dr. Coye to help us begin to understand what others are doing in the space of innovation. Because we believe that Loma Linda has been called to a very special purpose in the Inland Empire. And to make that happen, it is really up to us to lead our organization as innovators as to how we begin changing the work that we do, and at the same time leading across the Inland Empire, where Loma Linda really can assert itself as a leader in the field of innovation of how we make the Inland Empire a better place to live and a healthier place. So before I turn it over to Dr. Dora Barilla, let's bow our heads for a word of prayer. Our Father in heaven, we thank you for the opportunity to come together, to learn, and to look for ways in which we can better carry out the mission to which we've been called. I want to thank for each person here today. Bless them in a very special way and open our minds and our hearts to what we can learn. In Jesus' name, amen. Okay, so I'd like to introduce to you the Associate Vice President. Oh, I guess I didn't introduce myself. My name is Rick Rawson. I'm the CEO of Loma Linda University Medical Center Murrieta, and I also serve as the Senior Vice President for Strategic Planning for Loma Linda University Health. And I'll turn it over to Dr. Dora Barilla, who's the Associate Vice President for Strategy and Innovation.
Thank you, Rick, and thank you all for coming today. Dr. Coye is testing Loma Linda's innovative abilities today. So unfortunately, we had terrible traffic problems, but I said this is a reciprocity. The first time I went to one of her LA Innovates, I was literally stuck in traffic going down to the VA in downtown LA, and after 2 hours of being stuck in traffic, I sat down and she said, well, now that the meeting is over, so I said, clearly understand the challenges with traffic, but very grateful for her to be able to be innovative and at least be with us via WebEx. But Dr. Coye, we are very blessed today and very fortunate to have someone of her caliber. When I first met Dr. Coye, she was the Chief Innovation Officer at UCLA, and she clearly got it. And I really couldn't figure out, she literally spent hours mentoring me and showing me how, the innovative process works, what innovation was. And it was really, her whole premise is that it's about scaling and leveraging and sharing. And that to be able to innovate, we're gonna have to learn how to scale things. So I'm going to give you a little bit of her background so you can understand the caliber of individual that Dr. Coye is. And she is truly a friend to Loma Linda. She's invited us down to the innovative collaboratives that they have in LA, and we've already learned so much and connected with so many people. But as I said, Dr. Molly Coye is the Chief Innovation Officer at UCLA and the Director of the Institute for Innovation of Health at UCLA, where she leads the health system in identifying new strategies, technologies, products, and services to support the large-scale transformation of healthcare. Dr. Coye also advises many technological developers, investors, national health systems, and policymakers about disruptive technology and business models that accelerate transformation and constrain health expenditure. She has been listed as one of healthcare's most influential leaders, and I can attest to that. She invited me down to the Martin Luther King Innovation Summit, and there was about 60 people in the lobby of the new hospital down there. And I said, you didn't tell me it was the who's who of healthcare. Literally, I should have brought my autograph book because everyone was listening intently to what Dr. Coye had to say. They wanted to hear, holding on to every word, and really praising her work in healthcare. But in addition to that, I just want to talk about a few other appointments that she has had. She was the Commissioner of Health for the state of New Jersey. She was the Director of California State Department of Health Services and the Head of Division of Public Health Practice at Johns Hopkins School of Hygiene and Public Health. She's an elected member of the Institute of Medicine. And her board, she'll have a few disclaimers and endless boards. But like I said, we are very fortunate to have her mentoring us and leading us along as we move forward into really a transformation of the Inland Empire and the region. So without further ado, I think our technology, she advised us on how to get it all up and running, and John is here to walk us through that. I turn it over to you. Thank you, Dr. Coye.
Well, thank you very much for that generous introduction, and I apologize to everybody that the forces of the traffic gods were not helping me particularly this morning. So we're using technology to deliver this talk. Let me start, and my hope is to talk to you about the challenges of the future and how innovation can help meet that, because I know from my time as state health director in California that your success in your community and your county has made it one of the healthiest areas in the United States. So, in fact, your opportunities and challenges you face are somewhat different. Some pieces of it are similar to the rest of the country. You really have opportunities to continue to step forward and be leaders. So let me start here with Moneyball. Now, if I was there in person, I would ask you to raise your hand if you've seen the movie Moneyball. Well, all right, here's your assignment. Your homework from today's session is to download Moneyball and watch it. And the reason is because Moneyball is about baseball, but it's also about absolutely spot on the challenges that we face in healthcare. Let me just read you a few of the quotes, and we play a game with lots of our audiences and here at UCLA of how many analogies to healthcare we can find in this movie. Think about these quotes. First quote is, not surprisingly, we need more money. Secondly, we've got to think differently. We're asking all the wrong questions. Your goal shouldn't be to buy players. It should be to buy runs. And the analogy there is don't just buy big-name doctors, go after outcomes. And one of the ones that I like best is, we're the card counters at the blackjack table, and we're going to turn the odds on the casino. Now, I'm not a gambler, so I may be disqualified in my reaction to this, but basically what he's saying is they're using epidemiology. They're using the numbers, and that's what we have to do, is start thinking in terms of populations and broad numbers and how to move the health of people. There also are some pretty direct quotes in there. Adapt or die. And I don't think Loma is at risk, but there are many hospitals and medical practices that are going to have a lot of difficulty in the future because they can't adapt to what consumers really want and need. And the other sad lament, which we hear in healthcare all the time, is when one of the coaches says, Billy Bean has tried to reinvent a system that's been working for years, and his new system, it won't work. But what we're building are systems that do work. and that really do reinvent healthcare. So before I go through the rest of the talk, a few disclosures. I'm a member of the board of directors of Aetna for the last 10 years. And so I have a perspective that's both from the health plan and the provider side, as well as my public health background. I'm also chair of the board of directors of an online behavioral health company that was started with the National Health Service in Great Britain and is now coming to the U.S., Big White Wall. As head of the Global Lab for Innovation and the Institute for Innovation at UCLA, however, we have no commercial revenue, so there's nothing to disclose particularly. And with the exception of showing one picture of Big White Wall, which is being considered at UCLA, there are no financial benefit to me from any of the other commercial products and services that I'm describing here. And that's very important because you should always know, especially in this era of innovation, what the ties are of a speaker to any of the products that they're discussing. So here is the way we would have thought of satisfaction really as recently as 3 or 4 years ago. But we're having to move off the idea that what we want are just satisfied customers, that our patients, when they come to us, when they're in the clinic or when they're in the hospital, have a high degree of satisfaction. At UCLA, we've climbed that hurdle. When David Feinberg, our CEO, arrived as CEO about 5 years ago, UCLA was at about 38th percentile of all academic health systems. In terms of only 38% of our patients would recommend us to another patient or return to us. That's pretty, maybe not as bad as you can get, but pretty darn bad. David has said that the attitude of our medical staff was essentially, you're lucky you're here at UCLA. And they went to work on changing that. And within about 2 years, they got to the top of all the academic medical centers for patient satisfaction and 96th to 98th percentile of the entire hospital industry. But as David says, and I believe, that's being the best of a bad lot, because it still means that roughly 15% of the people who come to you are not happy about the care they receive. So you can get very good at patient satisfaction. You can be the top of the heap. And even in terms of patient satisfaction, not be as good as a lot of the other sectors of industry out there. But more importantly, we have to change our metrics because now our patients become engaged and activated in a digital world, and that is really changing how we think about satisfaction and moving it to engagement. And a big part of that is that it's not just amenities, it's not even just how we treat them in terms of our personal interaction with the patient. It's also the tools and services we provide them to manage their own health and their own life. So I'm going to show you a number of innovations. Some are commercial and some of them are just changes in the way you deliver a service that have a huge impact on quality, on satisfaction, on cost, on recovery rates, on a number of outcomes that are very important. So this is a very simple device that our rehabilitation experts at UCLA built, which is essentially a reclining bicycle. You can use it lying down in bed, over the side of the bed. But what they did is they linked up a feedback system to an iPhone or an Android taped to the machine so that the patient can see every day how much better they're doing than the day before. And by using that gizmo, they cut the rehabilitation from stroke by 30%. So giving patients simple tools and feedback to encourage them to improve their health and performance is a very powerful tool. As a matter of fact, if this actually were in an FDA trial as a pharmaceutical, we would probably conclude the trial early and allow it to be used with everyone. So this is one of the examples of helping patients There also are ways to use the digital support mechanisms to change the nature of clinical practice. And Dora, again, I would ask, is anyone at Loma Linda using Visual DX? Could you ask anyone who has seen that or is using it to put up their hand? A couple of people? Okay, thank you. That's easier to hear that way. Well, this is a system that was developed at the University of Rochester, and actually one of the faculty members at UCLA was a part of doing it too. And it started with dermatology, but it's now spreading to many other specialties where the physical exam is important. And essentially what it does is change the way a physician gets supported. Traditionally now, a lot of physicians might go online to UpToDate, and you'd say, well, I want to read about psoriasis, and you read everything about it and you see some pictures. This helps you go through the differential step by step. And it was, for example, one of the top apps, according to Harvard medical students, which is a sort of interesting recognition. It's had a TED-Med award, but it also has been accepted and endorsed by the Veterans Administration and by CDC and a number of other very critical audiences. So these are the ways that we can actually change clinical practice and enable our patients. And I'm going to take you through a series of those examples because I'm presenting to you two ways to look at the strategic importance of innovation for the future. The first is patient-centered innovation. For patient-centered innovation, I would take that phrase away from patient-centered primary care or patient-centered medical home. Because what we want to do is have patient-centered care follow the patient wherever they are, and in many cases prevent them from ever having to be in the medical home or in a clinic or a hospital. So patient-centered innovation, and let me give you an example of that. What we've been doing at UCLA is ethnographic research, and this is actually, it sounds very complicated. It isn't. We built a toolkit, and we're glad to share it with anybody at no cost. But basically, our departments, so for example, the urology department and also our medical surgical group that's developing a common pathway for pre-op or pre-procedure and post care, have all done this kind of ethnographic research. What it means is going into the home with video and doing in-depth interviews with patients and stakeholders in order to understand their needs, pain points, and the pattern of their whole care pathway. You can see in the background here on the slide the chart of the patient pathway for the surgical home. And when it's above the horizontal line, then the patients are feeling confident and happy with what's happening to them. When it's below, they're worried, they're afraid, they're in pain. And so you do all of that deep interviewing, and you also, of course, interview all of the subject matter experts, the urologists and the experts on quality and safety, et cetera. And they come together and redesign care for the patient. And I'm ashamed to say that a large number of our urologists were, for example, quite shocked to learn how much of a problem managing a catheter is for the normal patient, how much uncertainty it provokes. So there are some very significant learnings when you do that. And then there are very typical learnings, like the doctor was looking down at his computer and typing instead of looking at me. And I'll show you in a minute the innovation that we're adopting that deals with that problem, which uses Google Glass and remote transcribing so the computer doesn't play a role in the office visit in primary care. The consumers are ready for this kind of change. This is a big 8-country survey by Intel, finding that 70% of consumers would use sensors in their toilet like the Japanese have for the last 5 or 6 years, prescription bottles, the cap sensors, or even swallowed monitors and pills. 64% of them prefer that their doctor give them a personalized regimen, not a general way to treat hypertension, but a personalized one based on their own data that changes day by day according to how they're doing. And 53% would trust the test that they personally administered as much or more than if it came from a doctor. So the doctor in the future, instead of writing an order for a test and sending them to a lab, can have them do the test themselves at home, and they'll feel quite confident about it. The second area for innovation is to make care affordable. And I'm sure you've all seen lots of the data about how much more of the consumer's paycheck healthcare costs now than it did 10 years ago. The rate of inflation in healthcare has far exceeded inflation in the rise of wages. But the urgency is even greater than it's usually described. If you look at what lies ahead of us in terms of boomer generation and retirement, because it's the Medicare population that has the greatest burden of illness, 75% of Americans nearing retirement age in 2010 had less than $30,000 total in their retirement account. That means that they are one or two bad diagnoses away from being broke. So we're going to be dealing with patients who have to make very painful choices. Almost half of middle-class workers will be poor or near poor in their retirement, living on a food budget, for example, of about $5 a day. So it is far more urgent than we have generally believed that we make healthcare affordable, convenient, available in the home, and not dependent on the expensive systems that we have built at this point. I would say that the analogy here is that we've been busy building Model Ts. A lot of people think innovation is just inventing a new gizmo like Alexander Bell and the telephone. In the last 10 years, as we've worked on quality and redesigning care pathways, we're doing sort of what Henry Ford did when he standardized the production of the automobile. But what we need to be doing is a lot more like the Google self-drive car. We need self-drive patients. We need patients to be enabled to do as much of the care for themselves with our remote support as possible. And I do realize that Loma Linda has long been a leader in telemedicine and telehealth. So once again, you have a great platform to build on for the future. So we believe at UCLA that our challenge is not to invent new things. If you're in an academic center as well. In an academic center, everybody's job is to invent new things. Every faculty member's job is to invent new things. But invention to full-scale penetration of the market and deployment is usually a 5 to 7 year period, and we need faster progress. So without shutting down the inventions that the faculty are working on, in the health system, we believe we need an innovation capability that focuses on scanning across the country and now increasingly across the world to identify, bring in, pilot, and if it's successful, deploy high-value innovations that will deliver better health and greater value to more people. Now, to do that, it does mean sometimes building things, and I'll show you a couple of the things like that little bed fitness device that we have built, but mostly it's to beg, borrow, and steal whenever we can, and to link always to strategic imperatives. With every innovation we think about, we think, is this going to make a difference? We only have so much bandwidth, so many people, so much capital. So it really needs to be something that, if it was successful, would make a big difference and drive towards what we call the 20% solution. And that means we want to understand how, if you take really important cost, access, satisfaction, and clinical outcomes, what innovations, and sometimes it's a bundle of innovations, not one innovation, will help you actually bring down the total cost by 20%, increase access by 20%, and make the results clinically 20% better. By setting that kind of goal, you don't waste your time on a lot of things that are pretty marginal. So there are 4 things that we do in order to try and accomplish this. The first thing is identifying innovations to scale. And we're looking for strategic alignment, documented success in early pilots, potential high value. In other words, if they had the same result for us, would it help with the 20% solution? And scalability. There's some things that are easier to scale and other things that are very difficult. We don't need to reinvent the wheel. Innovations can come from within or outside UCLA, from healthcare providers and payers, or other sectors entirely. We then pilot, evaluate, and deploy, and we've made that into a measured process with all the steps very recognizable, and we have collaboration from our legal division and compliance and IT and finance, et cetera, in order to facilitate a rapid pilot so that we can quickly tell whether something is going to be worth scaling. We build a strong innovation process and culture, and we do that especially by now. We have 10 innovation officers in different departments and divisions throughout the health system who are seed bearers and promoters of innovation in each of those units. We also have contests. And in our last contest, which was for innovations that would advance the patient experience, we had 2,000 of our employees and staff out of a total of 10 participated in it, and we had 50 new innovations that were competing. So we have pretty broad participation in this. And finally, more recently, we've been working on connecting with the global innovation community because more and more things invented in India or in England are going to be worth using here in the United States. So the process we go through is a pretty disciplined process. Scanning, learning about what else is out there and what our needs are, listening internally, then piloting, and finally deploying. And everything that we are testing, everything that we finish, and the results of our finished testing are available to share with everybody else around the country or the world that is interested in innovation. So here's a quick smattering of some of the things that we have adopted and are either piloting now or deploying large scale. So in the center bottom are the UCLA care coordinators. This is a new way of using care coordinators. On the East Coast, they tend to take nurses or nurse practitioners and put one in every clinic. We decided to test out using non-licensed personnel. So we took returned medical vets, social workers, medical assistants, vetted them for personality capabilities and knowledge and intelligence and their interest in problem solving and capabilities for problem solving. And we put one in every clinic, and we have had 92% physician satisfaction, huge patient satisfaction. Within 6 months, in a pretty tightly managed population, we decreased emergency room use by a further 30% and hospitalizations by 20%. So we really have made a big difference. LifeImage is a cloud-based image sharing technology, which we're using for all the patients who are referred into us from other systems, so they don't have to mail CDs of their images or drive the discs in, and we no longer have the shifting piles of CDs on everybody's desk. Hypnosis is online diagnosis and treatment, and Augmetics is the Google Glass for remote transcription of medical encounters. Big Point Wall is the company I mentioned that I have taken a role with, and it's online behavioral health. Tonic is another example. Tonic is an iPad-based survey system that is highly configurable. So in our primary care clinics, whenever the physicians want to add a new survey, a new set of questions to find out about something, we use it for the basics on depression screening and intake and registration, but we can add all kinds of other surveys to it, and there's high satisfaction from the patients and the office staff. We also are working, if you see in the upper left, with the remote monitoring in the home. The Veterans Administration was the pioneer in this, and they now have about 500,000 veterans being monitored in their home with chronic diseases. So we've been leading a 5-campus study of that as well. I mentioned hypnosis for the online diagnosis and treatment. We're considering adopting Teledoc, which is a system developed for employers that does just telephone or video talk with a physician when an employee wakes up in the morning with a minor acute illness and doesn't know whether they need to stay home or go to an emergency room or they can wait for a doctor visit. So it's a consultation on that. And that's cut absenteeism for employees by 50%. And perhaps the most exciting new innovation is the e-referral, e-consult model. This is really a pretty breathtaking system. It was developed first in San Francisco and brought to Los Angeles, and it's now being done by the county system, and we're starting to do it at UCLA. It's also been done by Mayo Clinic very successfully. Basically, what it does is set up an email curbside consult from primary care to specialists that takes out the need for 20 to 40% of in-person visits by the primary care patient to the specialist. And it's very successful, and it's a great example of something that makes life simpler for the patient. They don't have to travel for the specialist consultation. It brings down the cost of care, and it teaches the primary. So over time, the primary care physician learns a lot of things to manage them that they would have referred to a specialist. So it's been a very powerful system. So when we look at all of these, and you could ask, I mean, there are literally hundreds of innovations coming at us, and you could ask, well, how do you filter them? How do you figure out what you're going to pay attention to? What we did is we took the system focus on strategy, which you see at the top here, so primary care, secondary strategy and affiliations, tertiary and quaternary strategy and relationships, affiliations and partnerships with other large health systems, and insurance partnerships. All of those areas have strategies underway. And we interviewed all of the people involved in those different strategy areas, and we boiled it down into focusing on 4 key areas where we thought innovation could make a big difference. The first is in access to care. How do people get the care? And as I said, how can we, in many cases, reverse that so the care comes to them instead of them coming to the care? Population health. How can we manage a larger population without scaling up the resources equivalently as we grow the population that we're managing? Tertiary quaternary, we share with you as a concern, how do academic centers in the future improve our value, meaning the quality and not only satisfaction, but experience of the patient who comes to us in relationship to the cost, both for us to produce it and the price for the purchaser, whether it's government or private. And the last is, as I said, the global lab, where we're looking for innovations around the world. So this is our dashboard for fiscal 14. One of our areas of focus is the innovation system and culture. And the second part B there of establish the innovation leadership is the innovation officers in different departments and divisions. And they're playing a very active role. In scanning, part of that work that's very important is to have specific innovation objectives in each area of strategy. So that's a thoroughgoing conversation in the strategy areas. then a comprehensive assessment of potential strategies in some of the key areas here for population health and for access. Then testing and implementing, and you'll see down on D that we want to incorporate the e-referral system into EPIC, which we call Care Connect, in order to expand primary care physician use within UCLA. But I don't know where you are on your upgrades, et cetera, for EPIC or for, I'm sorry, I don't know which system you're using, but that's always a bandwidth challenge. So that's the one area where we're not sure we're going to get it all the way through. And then we're obviously in G, establishing our role in support of telemedicine and telehealth. And again, we should study at the feet of Loma Linda because you're way ahead of us in a lot of that. But if we look back over the last 3 years, this is a partial list of all of the innovations that we've been responsible for. Some of them are ones that we bring in and hand off to others. So, for example, we identified Crimson as an important part of our analytics structure and brought that in, and then the appropriate IT and clinical groups and strategic groups took over the management of that. The patient voice, third down under system building, is what I referred to as building the toolkit. So now other departments and divisions can use the ethnographic approach to understand what patient-centered innovation would be. And I'm going to show you a few of the others as we go forward. And Dora, I'm very glad to spend more time with you and a smaller team going through the specifics on each of these. So Zypnosis, we're about to launch as the California clinical partner. Zypnosis is online diagnosis and, if necessary, prescription for patients that are not necessarily the current patient of the online physician. So any patient anywhere in Los Angeles could go online and pay cash. In some states, they're now reimbursed through the insurer, and put in their symptoms, and the physician can either decide that it's appropriate to deal with that way or tell them, no, this really requires an in-person visit to an urgent care center or a physician's office. Virtual visits were developed by Mass General partners in Boston, and they basically said for lots of the common chronic diseases, we don't really need to physically have the patient come in for a follow-up visit for hypertension. We can develop a templated questionnaire that the patient fills out. We review that. If necessary, do a phone call or a video call with the patient, and in many cases, that's all that's needed for follow-up of the primary care visit. We also became the medical directors for Minute Clinic in Los Angeles and Orange County, and we've been sending our patients in primary care to CVS for follow-up visits for hypertension, or send them there for an immunization because it's more convenient. They don't pay for parking. It's a much better way of helping them get the care that they need. And the great thing is that this year, the Minute Clinic medical record is going to be integrated with Epic for us so that their nurse practitioners and we will be able to see each other's patients' records. Life image I mentioned before, this, because it's a very complicated technology investment, meaning it's central to imaging, took quite a while to get through the whole process of approvals, but once we got it in and up, it is spread like wildfire. It's throughout radiology, cardiology, and the emergency room now, and is a very high satisfier for both patients and physicians. Big White Wall, as I said, is an online behavioral health system. The one thing I would say about that is that we were delighted because when we brought this in for consideration at UCLA, which was before I was involved with the company, our psychiatry department was very supportive. They said there aren't enough resources around the country, even if we could get everybody who needs some kind of psychiatric evaluation or treatment into treatment, we wouldn't have the resources, so we need to begin looking at these kinds of solutions. We also have started a pilot it's been going for about a year and a half now, with UCLA employees as the employer for population health. Now, you're probably in a better situation than we are for that. First of all, you have a long history of prevention and emphasis on that. And secondly, you probably have more say over the ability to negotiate and make decisions about employee health benefits. Ours are really determined by the University of California system centrally. But we got the authority to do this pilot, and we're working with a company called U.S. Preventive Medicine, which we find to be very evidence-based and very successful. And we've been working closely with them, and I'll describe that process. But the best news is that in comparison with the general UC wellness program, which gets about 16% participation in HRA, that we're getting 94% engagement. So we're really pleased about this. And this makes a very important point that many of the innovations that we're focusing on actually come from employer systems, because employers, like health plans, bear the risk, but employers have a concentrated group of employees, whereas health plans tend to have a fifth of this physician's practice, a tenth of that hospital's discharges, so it's much more scattered. With employers, you can really test out a lot of these systems. So Hypnosis, Teladoc, Tonic, Minute Clinic, and U.S. Preventive Medicine, all are systems that came out initially of work with employers. And so we believe that the future is to look at health improvement rather than just health repair. And it's good to have a partnership with employers. The Bon Secours Health System in Virginia is a partner of ours, and we've been learning from them because they took all their employees, about 12,000 employees, into a comprehensive employee health and wellness program. We've sort of exchanged, each of us have contributed pieces of the model, but because ours is just a pilot with 500 employees and they had all their employees, they have got phenomenal results. So they initially went down in 2012, their benefits expenses went down 4.4%, when the rest of Bon Secours outside of the Richmond area had an increase of almost 1%. Kaiser had gone up 4%, and self-funded health plans in general, according to Deloitte, went up 3%. In 2013, Bon Secours went down a further 2%, and we've just gotten the 2014, their fiscal 2014 figures, and that ended with a 9% further reduction. So it's possible, even with a pretty healthcare workforce that has access to full benefits, to dramatically increase or improve their care. So this is what we have in our pilot that we get on the, if you start in the upper left, we get 94% engagement for the HRA. Then they're sent for a biometric screening, and we get 79% participation in that. Then they're sent for coaching, and we get 74% participation in that. And then they choose a primary care provider and go for a primary care visit, and we're still better than 2/3 of them going for a primary care visit. And these people were asked to enroll because they weren't coming to primary care physicians. So this is a very big success, and we're very excited about it, and we hope that we'll be able to expand it in the future. The main point of all of this is that patient engagement is the magic key. This is the thing you have to focus on. As the Forbes healthcare blogger says, more than pharmaceuticals, patient engagement is the blockbuster drug of this century. So I'll just finish up very briefly. I mentioned the Global Lab. You can go online to UCLA Innovates and click on the Global Lab and see some of the systems that have come up, some of the innovations that have produced such high savings. Here are some examples from the Los Angeles area, because we scanned Los Angeles area first for innovation. There is a non-hospital emergency department services provider in LA, and there also are ones in Florida and a number of other areas, that reduce the care of the diagnoses that they care for by 60%. Kaiser and Partners in Care Foundation developed home-based palliative care for people in their last year of life that took out 38% of costs in the last year of life, which is a very substantial improvement. And Kaiser is now replicating that system nationally in all of their regions. And finally, the e-consult e-referral program, which in its most comprehensive application has been taking out up to 46% of the need for specialty consultations. So that's a short tour of what we're focusing on at the Institute for Innovation. We have been very involved, as you see in the lower left-hand side, in innovation weeks and ways to focus on what are the coming physical devices that are going to drive consumer capabilities. And we also sponsor an annual summit that was held in Boston. It was in Washington the year before, and I think next year it'll be back in Washington. But we invite you to go to the website and prowl around and see what you can learn there. And Dora, I think I should end there and see if there are any questions or comments. I'd be delighted to learn about anything that you all have underway as well.
Thank you, Molly. And as you guys think about I encourage you to ask questions of Molly, just to really appreciate her focus on not only on the innovations themselves, but the discipline of innovation. That's so critical, and that will really, I think, dictate the success of innovations in any organization. So anybody who would like to ask a question of Molly? Oh, yeah, okay. And we're going to have to kind of translate it to her, so.
So she mentioned Crimson as a key product that they had used there. I assume that's the advisory board tool, and if so, which Crimson product is she talking about?
The Crimson product, if you could clarify that, is that the advisory board product for innovation?
Yes, yes, it is. And the reason that we felt it was so important is because we thought that we needed the analytic capabilities in order to understand the impact rapidly of innovations as we brought in. Of course, our system decided to adopt Crimson for broader reasons in terms of clinical care improvement and management of resources, et cetera. But from an innovation point of view, it was mostly important to help us evaluate.
Okay, other questions?
Could I ask, have any of the innovations that I mentioned actually been adopted now at Loma Linda?
Partially, and there are several that you mentioned that we're in the process of evaluating.
Okay, well, we'd be glad.
Well, thank you, Dr.
Glad to be helpful on that.
Well, I would like to say thank you for the wonderful presentation. I've learned a lot. I'm a primary care provider. I just finished, and I'm moving on to start a primary care practice in a community where there is shortage of primary care providers, and it's going to be in a private care setting. I know majority of these innovations that you've mentioned are, could they be translated in a primary care setting outside of the big institutions? I know your focus.
Definitely. Yes, I think I heard quite clearly. They definitely are intended to, and as a matter of fact, a lot of our primary care is in the community out in Manhattan Beach or up along the 101, and we are beginning to join in joint ventures with other clinical practices that are not going to be employees of UCLA the way our current primary care practitioners are. And even for them, putting a care coordinator in their office, using some of the CVS, the virtual visits, hypnosis, many of these things could be incorporated. And when we're done with our pilot of augmentics, it also is something that could be used by other primary care practices.
I have just one thing, Molly, just if you could mention a little bit about LA Innovates. I thought that was really interesting how you brought together, we have a few community partners in the table, how you brought together kind of a regional collaborative.
What we started out with is we thought that good ideas and innovation come from everywhere. And it was really important to take a UCLA-centric view of the world. So we wound up looking around the entire globe, but we started out in LA and we invited about 2 years ago representatives interested in innovation from all the health systems in the region that we could get in contact with. And I think there's a total of about 20 different systems that have been participating. And we meet every 2 months for a couple of hours and we choose a topic like end of life. And everybody who has been working on something that is innovative, meaning it's a new approach that might have a pretty big impact, comes and presents what they're doing, and we share the information. And the conversations are great. We've gone through e-referral and end of life and frail elders care in the hospital and a number of innovations. All of those are listed on our website, and you can go look in the Global Lab. But in addition to that, I think in any area where you are in your county, having the provider groups get together and share innovations and talk about where they can get the biggest leverage from their efforts is very valuable.
Wonderful. Well, Dr. Coye, we want to thank you for making it work, and if you guys just want to give her a big round of applause. We were very grateful for your time, and I'm sure this won't be the last time that we connect and have you out here at Loma Linda. So I know a lot of people have an interest in your slides, but is there anything that you want to finish with?
No, just thank you very much, and I apologize for not managing to make it out there, and I'll look forward to collaborating in the future. We have a lot to learn from what you've done. Thank you.
Thank you, Dr. Coye. Have a great day. Bye-bye. Thank you all, and if anybody has any questions or has some interest in the innovation process, feel free to stay back, and our team is here to answer those. Thank you.